All yours, Sheila.
Thank you, sir. So, good evening, everyone, and welcome to today's webinar on dynamics of trust in the doctor-patient relationship in India by our eminent speaker, Dr. V Gopchandran. So, as you all know, trust forms the very foundation of effective healthcare. So it influences patient satisfaction, but also professional happiness and fulfillment. And ultimately, both of these are going to affect the outcome of our treatment also, right? So we have to understand consciously the trust dynamics because we have never explored this topic initially on the clinical side. So what are the factors that will be influencing the trust? Is it our communication? Is it the cultural barriers? Is it the changing patient awareness or patient outlook towards doctors? What are the challenges today? Is it general mistrust towards doctors? Are these the medical legal concerns? Is it the over influence of social media and the Google doctor? Is it commercialization of healthcare? So many factors are there which are ultimately influencing the doctor patient relationship. So let us think positively. How do we build and sustain trust in today's environment? So, do we have practical strategies? Is it empathy, transparency, effective communication, so many things? Is it something that doctors can actually do or should we do? So these things are something we'll be exploring today in our webinar. And in today's rapidly evolving landscape, trust, when it is being reshaped by so many factors, let us explore the dynamics of trust. Let us reflect on the challenges. Let us identify practical ways on how we can strengthen the doctor-patient relationship. So ultimately, what does it influence? It influences the stress factors of a doctor. And this is the ultimate foundation of our ASHA group today. So let us, without much ado, begin today's proceedings. And let me invite my teacher, Dr. Arun Kishore, to talk more about the ASHA group. Over to you, sir.
Thank you, Sheila. So welcome everyone to the 8th of the ASHA Lecture Series. We are honored to have Dr. Gopi Kumar, who's the President-elect of IMA Kerala, and an eminent speaker today, Dr. Vijay Gopchandran, who's done his PhD in this particular topic. So just briefly about ASHA in 2 minutes. It's a group which was forged to launch a support system for doctors undergoing stress or potentially undergoing stress. And it stands for accept, support, and help another. The group's philosophy is that we recognize that all doctors can undergo stress, and unless we experience and understand our stress, we cannot help another person. So doctors should help other doctors. And by acknowledging this, we can become better at supporting one another. So it's a support group, essentially dedicated to disseminating information and getting the narrative about professional stress much wider within the doctor community in India. And finally, we also hope to be able to work with other organizations to develop programs to support doctors. We have a few activities at the moment. We have these lectures which happen once in 2 to 3 months. We are in the 8th of our series today. We have a website, ashafordoctors.com. We have a Facebook page, a WhatsApp group. We also have a YouTube channel where you can view previous lectures and also other information. And then we have this discussion series. So welcome all of you, and thank you, Sheila, for giving me this time.
Thank you, sir. Now may I invite Dr. Alfred Samuel, sir, to introduce our chairperson today, the President-elect of IMA, Dr. Gopi Kumar. Over to you, sir. Alfred, sir.
Thank you, Dr. Sheila, Dr. Arun, Dr. Gopi, and all dear friends. Good evening to all of you. I'm really thankful for entrusting me this pleasant duty. It introduces my good friend, Dr. Gopi Kumar. He is from Trichur and had his MBBS from Government Medical College, Alleppey, and post-graduation ENT from Kasturba Medical College, Manipal. At present, he is working in CAM Hospital, Polarikara as ENT surgeon. He had held in various posts in ENT Association, IMA, and to enumerate few, he was the secretary of AOI Kerala in 2009-10 and president in 2015-16. Secretary AOI South Zone in 2016 to 18. He was the secretary of IMA Kerala State in 1921. Currently is secretary of IMA National Health Scheme and president-elect IMA Kerala State. This November, he will be taking over as president of IMA Kerala State during the state conference to be held at Varkala. And is married to Jyoti Menon, who retired as Assistant General Manager of BSNL Kerala. Two sons, both engineers, Akshay Menon and Avinash Menon, both of them working in multinational companies. And we, all of us in ASHA, look forward to have a very fruitful association with IMA next year when Dr. Gopi Kumar is going to be the state president, especially in the field of stress management or stress reduction programs among our members. With these viewers, I welcome Dr. Gopi Kumar.
Let me invite Dr. Gopi Kumar to inaugurate the session today. Over to you, sir.
Yeah. Good evening. Thank you, Dr. Alfred, for that nice introduction. And Dr. Arun, Dr. Shinja, Dr. Gopchandran, and everyone in this meeting. I'm very happy and thankful to be here this evening with you for this ASHA lecture series. A very, very important topic because we are finding it difficult in Kerala to increase the trust of the patients or the dynamics of the trust between patient and doctors, because that is the that equilibrium is very much needed for having a smooth and peaceful atmosphere where doctor and modern medicine doctor can work. So this trust, probably earlier it was a paternalistic care that the doctors were giving out for the patients, and there was not much questioning from the patient's part regarding the diagnosis, treatment, management, whatever the doctor says, they usually agree and they obey. But now things have changed, and probably what are the changes or what made the changes to this extent and going through, I would say probably the awareness, the increased awareness, the education. Now, take for example the case of Kerala, which has got the highest health indices, which is at par with probably the developed countries. It's just because of the increased literacy, especially the women literacy, because they came to know about the diseases, how to prevent them, how to about the hygiene, so on and so forth. This awareness probably has increased their knowledge about diseases, and they started interacting with the doctors and asking questions. So the attitude probably has changed. So probably we will have to have a direct discussion with the patient regarding the treatment, regarding the diagnosis, and then advise the treatment. A give and take policy has to be taken to increase the trust. That is what I feel. Probably that is why many a times a difference of opinion happens in between the patient and doctor in many cases. That is one of the changing dynamics in modern India, and especially in Kerala. But this has led to a lot of confusions. Probably the increase in the hospital attacks, the doctor attacks, is because of this misunderstanding and the lack of trust. Probably that is why what is happening. So for that purpose, too, the way forward will be good communication, probably listening to the patient and a good interaction. And the patient should know what is the status of the disease, what are you planning to do, and he should be convinced. And this is very, very important because many of the times we get a litigation, we are sued against because of these lack of communications and documentation. So communication, listening to the patients, discussing with them, and probably clearing most of the doubts of the patient regarding the disease, regarding the treatment, regarding management of disease, probably the need of the hour to have a cordial relationship or increasing the trust between the patient and the doctor. So that is what Indian Medical Association Kerala is doing also. We have started a communication team. We have trainers of communication, and we are giving training to each and every member as far as possible of Indian Medical Association members, or even modern medical doctors who are members of Indian Medical Association, to have effective communication with the patient, with the bystanders, and building up the trust once again. And so also, the impact of this decreased trust is on the doctors. The morale has gone a little down, so that many of the modern medical doctors are reluctant, or rather, it's not that they are not taking up challenges, but they think twice before taking up a challenge in the modern medicine treatment part. A bit hesitant, so to say, because we don't know whether you will have to appear before a court, you'll be involved in litigation, so on and so forth. So this has to change, and that has increased the stress of the doctor, the stress of the modern medicine practitioner, and which leads to many horrible incidents as well. To some extent, probably the suicide rates also may be increased in modern medical practitioners because of this stress. And apart from that, as Dr. CJ already mentioned regarding the social media harassments, the other influences, so on and so forth, all has contributed. But then probably a good listening, a good discussion, a good communication between the patient and doctor is the need of the hour to have a confidence build up. And that will help probably to increase the trust between patient and that is what in my whatever I have gathered regarding in my personal experience of treating the patients. And anyway, this is a very important session, very good session, and I'm very happy that I'm part of this meeting. And Dr. Gopchandran has much more to say about this, I know. So I'm not taking much of your time, and I'm very happy and I'll probably inaugurate this webinar series. Thank you. Thank you for inviting me very much.
Thank you, sir. Shaji sir has joined, and I think Jimmy has also joined now, members of the ASHA group. Let me introduce the speaker. I'm most honored to introduce our eminent speaker and researcher today, Dr. V Gopchandran. He is currently working as assistant professor at ESIC Medical College and Postgraduate Institute of Medical Sciences and Research at Chennai. Let me give a brief bio. He's an alumni of Madras Medical College, and he did his MD in community medicine from CMC Vellore. He has a considerable experience working in Rural Women's Social Education Center in Kanchipuram, And he's a recipient of the prestigious Inspire Fellowship from the Department of Science and Technology, Government of India. And he did obtain this for his doctoral thesis. And interestingly, the topic for his PhD work was trust in doctor-patient relationship. So he has done considerable effort and insight he has obtained in this topic. Apart from this, he has many other decorative positions, including working editor of Indian Journal of Medical Ethics. He's a consultant for WHO, and he has done immense work and publications in epidemiology and bioethical research. Now, above all, he is also the author of acclaimed book, Dynamics in the Doctor-Patient Relationship in India. So this deals with the relational, interpersonal, and ethical dimensions of trust between doctor and patient. So we are very fortunate to have such a speaker to talk about such a relevant topic. And in this milieu of system-wide erosion, as Gopikumar sir had mentioned, the erosion of trust in doctor-patient relationship in India. We can't wait to hear from Dr. Gopchandran how patients experience trust in their doctors and what we as doctors can contribute to improvement of this relationship towards stress-free professional life for the doctors. So over to you, Dr. Gopchandran.
Thank you, Dr. Shija. I'll share my screen if you would allow me to do that. Are you able to see my screen?
Yes, yes.
Okay, and you can hear me also, right?
Yes.
Thank you. So thank you very much for having me over. I take immense pleasure in delivering this talk. And thank you, Dr. Arun Kishore, for identifying me, approaching me for this. I would like to begin with a little bit of context about my positionality. How do I mean, what kind of experience and knowledge base do I have to give this talk? I did my, like I was introduced earlier, I did a PhD in public health about 10 years ago. And my topic of research was trust in the doctor-patient relationship. And it was largely empirical work. And I spoke to thousands of people at that time to just understand how trust relationships are built. And then basically after these, it's almost 10 years now since I finished that work. And subsequently, a lot has changed with respect to the doctor-patient relationship. Like many of the members in this group have pointed out earlier, a lot has changed, a lot has evolved in the last 10 to 15 years. And whatever I'll be talking about today comes from a mixture of what I did during my PhD work, as well as the overall perspective of how things have changed with respect to doctor-patient relationships in India. So my worldview comes from a largely rural practice, and my practice has been primary care based, and it has been a largely outpatient based practice. I do not do hospital based medicine, and because of this, that is my worldview, and it's from that worldview that I'm going to be presenting today's talk. So let me first begin by framing my topic. For framing my topic, I would prefer to first define what is trust. Then I would like to define what is doctor-patient relationship. Now, trust is a very interesting word because when I started working on trust, in my mother tongue Tamil, trust is very loosely translated as nambikai. And I'm sure there are translations of the word in Malayalam also and all other Indian languages. But what is interesting is that we never get an very, very accurate translation of trust, which captures the actual essence of what trust means in any local language. This is probably because trust has never been something which we consciously needed to build, which we consciously needed to cultivate with people. It was very inherent in our societies, and probably that's why the language did not need a word like that. But let us take recourse to what Western literature and medical literature talk about as trust. So, trust is defined as an optimistic acceptance of vulnerability in a relationship. So, there is a doctor-patient relationship. There is an inherent power differential. There is a vulnerability here. The patient is the vulnerable party. And so, in that relationships of vulnerability, there is an optimistic acceptance that the person who is trusted will do whatever is in the best interest of the person who is trusting. So this is a trust, and trust is basically viewed from two angles. One of them is trust based on competence. The other one is trust based on character. So when a patient is trying to build trust with their doctor, they are building it on two planes. One is they are trying to build it on competence of the physician. How learned is my physician? How skillful is my physician? How many, probably they are even looking at what degrees they have, where they have studied. And they have looked at things like, are they able to provide cure to me? Are they able to provide relief to my suffering? That is the judgment of competence. And then there is judgment of character. Is the how reliable, dependable, how I mean, will the doctor protect my confidentiality? Is the doctor an honest person? So these are all the things which are relational in nature, and so character. So competence and character are the two angles in which people build trust. So that is about a definition of trust. Then I would like to define what is a doctor-patient relationship. Doctor-patient relationship is typically characterized as a fiduciary relationship. So in legalese, in legal language, it is known as a fiduciary relationship, where there are three components to this fiduciary. One, there is a beneficiary. The beneficiary is the vulnerable party or the patient. And then there is the fiduciary. The fiduciary is the powerful party, in this case, the doctor, who has discretionary capacities to make decisions on things which will influence the outcomes in this relationship. Like, for example, decisions regarding treatment, decisions regarding prognosis, those kinds of things. And then the third and probably the most crucial element is the fiduciary avoids conflicts of interest, and they do not consider their own self-interests, but put the interests of the beneficiary over and above their own personal interests. So this tripartite component is known as the doctor-patient relationship. This is very inherent. So if you look at the definition of trust on one hand and the definition of doctor-patient relationship on the other hand, you can see these are completely mixed with each other. They are intertwined with each other. Trust involves an acceptance of vulnerability, and the doctor-patient relationship, the fiduciary nature of the doctor-patient relationship, it involves that kind of a trusting relationship. So this is the broader framework on which I'm going to base my talk. So what I propose to do in the subsequent few minutes is to tell you how, what are the various social, cultural, political influences on the doctor-patient relationship. There have been so many. I'm going to pick just 5 of these influences, probably a very, very important set of influences, and how they actually influence the doctor-patient relationship. That's what I'm going to be talking about. Largely, my talk will be deriving from a lot of anecdotes, a lot of examples of things that have happened in my practice. So I had a student who was in a very, by the way, I no longer work for the ESIC Medical College. I resigned my job 2 years ago. Largely, I'm a primary care practitioner now. I do only community-based clinical practice of general practice. So I had a student, when I was in the college, I had a student who was in a steady relationship with his partner. They got pregnant unintentionally. So this was during college time, unintentional pregnancies, they keep happening. So they sought my help. So what I did was I made a few phone calls. And within a very, very short span of time, within a few hours, I was able to arrange for the student to meet a gynecologist, get a medical termination of pregnancy, and the whole thing was over within the same day. And within a week, everything was back to normal. So this was happening on one side. And last 2 months ago, I had a patient. She belongs to a marginalized tribal community. So there is a one tribal pocket in one of the rural areas where I work. So this girl, she is 16 years old and she's married. So her husband is 20 years old. And these two people came because the wife, the 16-year-old girl, is now pregnant. And she is also facing her final year board exams, school board exams, and she does not want the pregnancy now. So this is the situation. But already 12 weeks had crossed, so I cannot do a medical termination at the primary care level. I had to refer her to the district hospital. So I referred her to the district hospital. And so you can imagine what would have happened to this girl. There she was made to come back repeatedly to the hospital. She was judged for wanting an abortion. She was coerced to have the baby, deal with the exam later, have the baby now. And then she was scolded for not using birth control. Then her entire family was chastised for marrying at such a young age. And then all of this was happening. And ultimately, yes, she did get her medical termination. She went on to complete school. But before that could happen, so much had happened. She had been physically hurt, she lost her dignity, and she went through immense mental trauma. So, this indignity is something which is extremely common and it is extremely, it's there all over the place. So, it is in this context that I would like to talk to you about a work of a very good friend of mine, Dr. Supriya Subramani. Supriya did phenomenology work. She did qualitative work with patients in and around Chennai. So she went to hospitals and looked at the phenomenon of humiliation in patient care in India. So she did not travel widely throughout India, but it was largely Chennai-based work, and she spoke to patients both at private and public hospitals, government hospitals. And her finding was quite shocking because there was a ubiquitous presence of a passive culture among patients. I mean, doctors in many of these settings, intentionally or unintentionally, many times unintentionally, expected patients to be passive recipients of care. So when a patient had a different perspective, or when a patient did not meet a certain format of expected behavior, then that led to a dismissal of their agency, and that is humiliation, in other words. So Supriya's work, you can read it in this book. Routledge has published this book. It was recently released, and it was very widely disseminated among circles like this, circles like ASHA, where doctors are consciously reflecting on better ways to practice medicine. I think this is an interesting and important book to read. And then I'm reminded of Veer Das. So Veer Das, a very, very famous stand-up comedian, he delivered an interesting and a highly controversial monologue during his performance in the Kennedy Center in Washington, D.C. in November 2021. So this is just a screenshot of his YouTube video. It's there on YouTube for you to see. This monologue was titled, "I Am From Two Indias." And in this, Veer Das talks about how there are two Indias within India. One India which is affluent, which is progressive, which is developed. Another India which is still very backward. And when I talk about health inequities, when I talk about trust in doctor-patient relationships, this is the kind of India that comes to my mind. On one hand, we have the high level of mistrust and doubts in doctors coming from free and liberal access to information. We have so much information, we have so much knowledge in our fingertips, and there is excessive choices, so many alternatives to do doctor shopping, that we have these among these upper class elite urban population, that we have mistrust. And the exact opposite also is true, where we have populations like this girl, the 16-year-old tribal girl whom I spoke about, who belong to marginalized communities, abject poverty, vulnerability, lack of access to information, and there also there is this mistrust. So mistrust having two different facets and two different phases, and that's the kind of thing I am reminded of when I think about trust in doctor-patient relationships. And health inequities play a huge role in perpetuating mistrust and in influencing trust in the doctor-patient relationship. The second dimension of this whole trust phenomenon that I am taking for discussion today is professionalization. One thing that has happened, the past 4 decades, one thing that has happened is the emergence of professionalization of medical practice. So in the times when I was a child, when my mother was caring for me, I mean, took me to a pediatrician, those days, the kind of doctor-patient relationships. And then when I was growing up, when I was a boy, and we had a general practitioner in our street to whom we used to go, that kind of doctor-patient relationship that I remember, and the kind of doctor-patient relationship that we have today, one huge difference that I see is professionalization. So what do we mean by professionalization? Is that there is a very clear, distinct boundaries that are drawn between the doctor's personal time and the clinical time that a doctor provides for their patients. Now, I can tell you some anecdotes. Even today in my rural clinic, professionalization has not really taken place. The other day, I was traveling to my clinic. On days when I go from Chennai to my clinic, I have to take the suburban train and then take the bus, and then I have to go to reach the clinic. So I was sitting in the bus, and there is this young man who's also traveling to my clinic to see me in the place, and he's also traveling in the same bus. And both of us are sitting next to each other. And he immediately exposed his abdomen there in the bus, and he started showing me his skin rash, and he started asking me for consultation right then and there. For him, it is cutting short one journey to that clinic. He can finish off the consultation in the bus, get some prescription, and go away. And that's the way he's thinking. And those are the kind of professional boundaries with which I work on a day-to-day basis. But then that is a rural India, that is the India of poverty, that is the India that Veerda spoke about. But then we also see now the kind of professionalization where there is a very distinct what is known as clinical detachment with our patients. There is a line where we know that these are the boundaries. Beyond this, I will not breach this boundary and enter into your personal space. I can see people belonging to my generation, my parents' generation, who are caught in between this professionalization and the personal contact with the doctor. They are caught somewhere in between, and that's the area where trust problems start emerging. The line between what is clinical detachment and what is depersonalization, that is complete not seeing the patient as a person at all, dissociating them from a very personal contact, that depersonalization versus clinical detachment, that line is very fine, and it is in treading that line that many breaches of trust take place. So professionalization is one of the important things that have developed in the past few years, and this is an important reason why we have trust issues. The next thing that has happened quite interestingly is technocentric medical practice. Stethoscope used to be a crucial part of all our medical practice. All of us who belong to that generation where we used to auscultate for heart sounds, where we used to listen to S1, S2, and then murmurs and pick up diagnosis, where we used to listen to lung sounds. That generation, stethoscope was a very, very useful instrument. And then subsequently, it has been replaced. A stethoscope has almost become an ornament now that young doctors wear in their necks just to identify themselves as doctors, distinguish them from others in the hospital environment. And a lot of technology has taken the space between the doctor and the patient. So when everything was clinical, when everything was palpation, percussion, auscultation, then talking to the patient, history taking, in those days, the separation between the doctor and the patient was limited. There was a lot of proximity between them. And then when technology took over, when imaging took over, when more accurate ways of identifying problems took over, the separation between the doctor and the patient has become quite significant. So this is what happens in my clinic. When a new patient visits, the routine is to set aside all old reports, old records, scans, x-rays, lab reports, everything. And then I'll just say, let us first talk. And then we'll have a conversation and then a physical examination. Then only we go into these reports. Many of my patients are surprised when they see this happening, because they all have these thick files and bags of reports with them. So they are surprised that clinical contact, touch, conversations are all given priority over all those reams and reams of reports for which they have spent a lot of money. But then that has become a rare practice today. Many clinical consultations begin with some kind of an image or some kind of a laboratory test. Clinical maneuvers like palpation, putting the bell of the stethoscope on the chest to listen, then palpating the abdomen, just touching the wrist to palpate the pulse. These are all not just diagnostic maneuvers, but they have deep therapeutic value. For many patients, just the touch has such a huge therapeutic kind of a relationship with the doctor. And on screen, you can see Abraham Verghese. He gave this phenomenal talk in July 2011. You can see it on the screen in Edinburgh, Scotland. He gave this talk, and this was recorded, and it has more than like 5 lakh views on YouTube. You can just go and watch it. It's one of the most inspiring talks, 18 minutes in duration, delivered 15 years ago, but still relevant today. It talks about the power of touch in the clinical encounter, the power of the clinical examination, the ritual of clinic. He calls it the ritual of clinical examination, and how it has so many it transcends so many barriers between the doctor and the patient and establishes the trust in the doctor-patient relationship. So the technocentricity of our practice of medicine is one of the reasons for the distance between the doctor and the patient and deterioration of the doctor-patient relationship. The next thing that is quite prominent now, almost impossible to live without, is the phenomenon of specialization. Gone are the days when an MBBS graduate would begin a general practice. Almost there is nobody who goes from MBBS to do general practice. In fact, when I was in college, there was this one young man from the 2017 batch. He joined MBBS in 2017, finished in 2021, and he was the only person in those 8 years when I was in college. He was the only guy who actually started his general practice immediately after MBBS. And he's doing quite well now. He works in his own hometown village. He will definitely go on to do a post-graduation at some point. But what is inspiring is that he actually decided to start general practice immediately post-MBBS. A lot of market influences, a lot of perverse forces in the medical practice industry have actually demotivated people from starting general practice post MBBS and push them towards specialization. I used to work in the medical college, like I told you earlier, and a typical patient would get admitted to the general medicine ward for fever. And a cardiologist would be called in for consultation on the blood pressure, endocrinologist for consultation on the sugar values, a surgeon for the foot ulcer care, and a gynecologist to screen for reproductive infections. She would have been admitted for a fever. So this is the kind, and every specialist who visits her would write beautiful case notes in her case sheet. All kinds of tests would be ordered, and all the reports would be attached to the case sheet. The case sheet would be really impressive, but the patient would have no clue of what is happening with her. Nobody would have the time to sit with her and explain this is why a cardiologist came, this is why an endocrinologist was in the picture, and so on and so forth. And that's the status of many patients who are admitted to tertiary and quaternary specialty hospitals. At this juncture, I'm reminded of David Epstein's book that you see on the screen, Range, Why Generalists Triumph in a Specialized World. This book was published in 2019. I read it during the COVID times, 2020-21, and it's one of the most impactful books I have read in recent days, because David Epstein talks about, he challenges the notions of Malcolm Gladwell. Malcolm Gladwell, in his very impressive book, writes about the 10,000 hour rule. He says if you specialize and spend 10,000 hours mastering a particular skill, repeated practice of a particular skill, you become a master of that skill. He talks about focused practice. And Epstein kind of says, he counter argues to this point and says, in today's era, there is so much specialization that what would be required or needed for tomorrow would be somebody who is a generalist, especially in the era of artificial intelligence. Many of these super focused and specialized tasks are getting automated. And in that context, what is required is somebody to look at the broader perspective, to look at the wider perspective, to look at the bigger picture, and look at how the bigger picture, how does all this fit into the bigger picture? Especially medicine. Especially medicine is such a complex scenario of practice that one needs to really have the broader picture to really get a hang of what exactly is happening with the patient. And unfortunately, specialization, super specialization, subspecialization, and going more and more narrow into a particular specialty is only ending up making things narrower and narrower, and removing the broader perspective to things that is very clear. Last week, I saw a 55-year-old lady who had rheumatoid arthritis, hypothyroidism, hypertension, and diabetes. She had all of these conditions. And her main problem, why she came to me, a primary care physician, was because she was having this burning sensation while passing urine for more than 6 months now. 4 months now. 4 months, she's had 6 different urine cultures. All cultures grew E. coli with significant colony counts, but she has never had a proper course of antibiotics so far. So she is seeing these various specialists, an endocrinologist for her diabetes, a cardiologist for her heart condition. She's seeing all these people, but there was nobody to really sit with her and talk to her about what is exactly troubling her generally in her body, not specifically what is happening with her heart or what is happening with her sugars. And therefore, a proper treatment of her urinary infection had not taken place. I just put her on simple urinary antiseptic nitrofurantoin, one of the cheapest antibiotics that you can see. And within a week, she had the first sterile urine culture in the past 4 months. And she was free of symptoms. And so far, nobody had really sat down with her and explained that rheumatoid arthritis and the steroids that she was taking and the diabetes was making her immunity poor, making her more vulnerable to urinary infections. How should she take care of her personal hygiene, urinary hygiene? None of those conversations have ever been happened with her in the past 6 months 4 months that she was suffering. This is what I mean when I say fragmentation of medical care that happens due to specialization. So this lady, she ended up not being able to trust anybody that she was seeing. None of these people that she had seen, she could have a trusting relationship with. So this is a major problem, another problem which is affecting our doctor-patient relationship dynamics. Another thing that the previous people who spoke have been talking about is commercialization of medicine and the doctor-patient relationship. One thing that is so common now is medicalization of common ailments, very common ailments. Like I see people having body pains because they went and had a hard day's work out in the field. And that has been medicalized now. Anybody with that kind of a body pain, they immediately go to a doctor, and a doctor puts in an IV fluid for them. Glucose, it's popularly known as glucose. And so they get that, and they immediately, there is a magical cure, and there's been no effort at any point to dispel the myth that an IV fluid will relieve all your body pains. An IV fluid is just water and salts. And how is it relieving body pains? That myth has not been debunked, and that has been perpetuated. And that is the level of medicalization of things, common ailments like body pains. And then commercialization of medical practice over and above this over medicalization. All of this has led to very, very high cost of healthcare and commercialization. Recently, I had a young patient, a 16-year-old boy who consumed rat killer poison. And he had, when he came to me, he already had coagulation abnormalities. He was very unstable. So I referred him to a tertiary care center. He was there in the critical care unit for a week. And then they referred him to a higher center because he required a liver transplantation. So you can imagine, from a rural setting, from a remote rural setting, a family which was an agrarian background, they go all the way to Chennai to get a liver transplant. All of this happened within a span of 1 month. And so ultimately he made it. This guy, he survived, he made it, and he came back. The initial narrative of gratitude slowly started dissipating. And what is the use of helping our son survive when we don't have food to eat? The doctor saved him, but grabbed everything we have and left us on the streets. This is the narrative. This is the narrative that comes from the father. And this is extremely common. People go out of their way to seek healthcare, to seek high quality, top-notch healthcare, but then they end up being they end up having catastrophic health expenditure and impoverished. This is the harsh reality of rising healthcare cost. And therefore, the same doctor who was God, who saved their life, over time, because of the financial realities, has become this person who has grabbed everything from them and left them on the streets impoverished. So this is not the problem of the doctor doing anything wrong or the doctor having any problems right there, but it is the systemic issue, the perverse systemic issue of excessive healthcare cost. And then, having said this, the other important issue that we are grappling with now is digitalization and the era of digital information and communication. Again, I'm reminded of Veer Das and what he said. There are two Indias here. One India, I can tell you, I narrate a very interesting anecdote. We are currently running a community-based diabetes peer support program in 26 villages where we work. So what we do is we record these small videos about diabetes, like foot care or dental care. We record these small videos, and then we have community health workers who take these videos in their mobile phones and they play it to these community members. And we have many of the diabetic patients in our village are elderly people. So when they see these small videos being played on the phone, and they also know me, they know my voice, and so they hear my voice and they see the video, they see me on the screen, they think it is a video call and they talk back to the phone. They have this engaged conversation with the phone, unaware of the fact that it is a asynchronous video call. So that is the digital divide that we live in India, where there are some people who cannot say tell apart the difference between an asynchronous conversation, a video conversation through a recorded video, and an actual video call. So they cannot say those differences. And then on the other hand, we have the phenomenon of cyberchondria, where there is excessive access to internet, excessive access to knowledge. Everybody gets on Google, gets on the information. Now with large language models, if you ask ChatGPT that these are the symptoms I have, what is the thing I'm suffering from, ChatGPT will give you a beautiful diagnosis. And people walk into the clinic with that kind of a diagnosis. And this is the digital divide that we have in our country. And this digital divide has greatly contributed to a lot of ways in which trust is hanging in the thread. So these are some 5 issues that I have identified to highlight today. And what do we do now? These are the problems that we have, and what do we do now? Do I have some more time? I need some 5 more minutes.
Yes, please.
Yeah. So one thing is, how do we navigate the doctor-patient relationship in this kind of a complex environment? So trust is actually a double-edged sword. So why do I say a double-edged sword? Because trust is good to have. It is good to have a trusting doctor. I mean, a trusting patient. I mean, this whole trust in the doctor-patient relationship has to be a bidirectional trust. The doctor has to trust the patient. The patient has to trust. I mean, the patient has to trust the doctor, number one. The doctor also now needs to trust the patient to a certain level. The doctor has to trust the patient to make the right decisions. The doctor has to trust the patient to actually do the right diligent thing of following the advice given by the doctor, because many people are just testing whether you're saying the right thing. They already are loaded with a lot of information. They're just walking into the clinic to test whether you're saying the right thing. So this whole trust, a bidirectional trust, how is it negotiated? And this trust is quite complex because, number one, having trust is a good thing, it is an important thing. But trust also makes us let down our guard in certain ways. And so when we let down our guard, we are more vulnerable to exploitation. So that is the very, very complex nature in which trust operates. Trust largely spreads through word of mouth in rural areas. Word of mouth is a very, very strong way through which trust operates. And then now we have things like Practo websites where doctors get star ratings. And so there is these star ratings are nothing but the word of mouth in a very digital environment. They are the word of mouth in a very, very modern way of looking at it. But one distinct difference is, when it is a word of mouth in a rural area, it is somebody I know, it is a neighbor, it is a relative who is recommending to me. But in Practo or in one of those online star ratings, it is an anonymous person who is giving me those ratings. And those ratings can also be bought. They can also be purchased. And we know that many of them are rigged. And so they are not as reliable. So the power of word of mouth is very strong. And the power of digital star ratings and digital rating of doctors is also now taking over. In all this context, how do we negotiate trust, and why should we even discuss about this whole trust in the doctor-patient relationship? Like Dr. Gopi Kumar sir was saying earlier, we used to have paternalistic practice of medicine. Doctors used to make decisions for their patients largely, and now we have moved towards a deliberative model where there is a shared decision making. I would like to briefly explain what shared decision making is and how we can do that, and then close the session with that, if that is okay. So 2 weeks ago, I had a 43-year-old patient, a lady in my clinic with systemic lupus erythematosus and lupus nephritis, and she was in end-stage kidney disease. She was in pulmonary edema. Her hemoglobin was only 3 grams per deciliter. She was a very, very classical patient who required immediate hemodialysis. She had been advised hemodialysis for the past 2 years, but she has never gone for a hemodialysis. She and her husband have been regular visitors to the rheumatology and nephrology clinics in the GH, General Hospital, and they have many close family friends whom they met in the waiting rooms of that hospital. Many of them SLE patients with kidney failure and who got hemodialysis subsequently, then gradually faded away and died within the next few years. So over their experience of seeing numerous such young people in the past years, they have now a sound understanding of what can reasonably be expected from the care pathway offered in a government health system. So having this knowledge, they have decided that they do not want hemodialysis. They just, but when they said this to their doctors, the doctors just sent her home, labeling her as AMA, against medical advice. This approach to clinical decision making that prioritizes biomedical knowledge and evidence over patients' own values and preferences is a huge impediment to the trust in the doctor-patient relationship. So this is where the role of shared decision making comes, where the relationship between doctor and patient is definitely there is a power asymmetry even today, but this is a bi-directional power asymmetry. And what do I mean by that? The doctor is the person who has knowledge about the body, but has zero knowledge or zero expertise over what the patient wants, what the patient experiences. On the other hand, the patient has full knowledge and experience over their lived experience, bodily experience, their values, their preferences, but very little knowledge about medicine. So there is a bi-directional power asymmetry. Doctors have knowledge in certain aspects, but do not have knowledge in certain others. And patients have knowledge in certain aspects and lack knowledge in certain others. So this is the bi-directional asymmetry of power with which the doctor-patient relationship has to be viewed today. And in this context, all decisions have to be shared. Like this lady with SLE who decided that she does not want hemodialysis must have a respectful conversation. There should be a space for a respectful conversation for that lady with her physician, her nephrologist, where she can have comfort care at home. She should not be labeled as against medical advice or a difficult patient, quote unquote, difficult patient, and then sent home without the care that she values. And that's where shared decision making comes. And that shared decision making is probably the renegotiation of trust, the renegotiation of the doctor patient relationship that is required for today. So thank you very much for patiently listening, and sorry if I have exceeded the time limits that I was given. And thank you very much, Dr. Arun Kishore, for giving me this opportunity, because all the reflections, conscious reflections on trust that I did was very intense during my PhD days. But in the past 10 years, I have not had the time or the opportunity to reflect so intensely on these issues. And the past 2 months that we have been interacting and I've been working on this has been really fruitful for me, because I've had this opportunity to rethink this and reflect on it. Thank you very much, and thank you. Now, thank you very much for this opportunity.
Thank you. Could we come out of your slideshow, Vijay? Yeah, thank you so much. Shija, back to you.
Yes, sir. Yeah, thank you so much for this very insightful talk. Actually, it had us thinking about a lot of things. Because thank you for sharing the patient perspective and the different scenarios, like you said, about the two Indias. We rarely give a conscious thought to the patient's perspective. So thank you for sharing that and all your experiences. And I'm sure that most of us are thinking about our own personal experiences with the patient and what we could have done differently. Like, I mean, we do label patients as difficult patients when patient is not listening to what we are saying. So definitely, like Sir said earlier, there is a patternistic kind of attitude instilled into us, probably from our training itself. And so it's time, I think, for doctors also to think differently about the relationship, and the dynamics are changing. So thank you so much for the wonderful talk, and I'm sure that everybody is having some comments to make and some experiences to share. Sir?
So could people put their comments into the chat box, or you can ask it directly if you have questions? Yes, Ananta. I think Ananta has got a question.
Yeah, sorry, I couldn't locate my hand, the virtual hand. I suppose it's yet another example of us being distanced through technology and having to use a virtual hand instead. But thank you, Dr. Gopichandran. I found that talk very insightful. I'm Ananta Dave, and I'm a psychiatrist by background. And I trained in India. I lived there for many years. I now live and work in the UK. And again, it made me reflect on several instances of my patient interactions over the years where I felt that I could have been less judgmental and done more to earn the trust and confidence of the patient. Although it is a two-way relationship, I mean, we are all human beings, so we do expect to be treated with dignity and respect as well in return. But the power differential, as you say, needs us to take that into account. I mean, in the context of this talk and the work of ASHA, I was thinking actually when we lose the trust and confidence of patients, or it's lacking in that doctor-patient relationship, it affects us quite a lot. And all the phenomenon that we see nowadays of moral injury, chronic stress, burnout, that feeling of detachment from work, the way burnout is described as an occupational condition, I think, in DSM. So all these things actually might arise from a trust deficit, not only between doctors and patients, from what I have seen, but also between colleagues. And because that time for relationship building seems to be disappearing or diminishing, and there isn't a value placed on that. I mean, Arun, you know these conversations in the UK. We often say, for example, that when we have a job plan, what is it that we do in the week? When we look at it, the emphasis is on numbers. How many patients have you seen? How many patients have you followed up? New patients, whatever. How many mental health act assessments have you done? But the amount of the time that you spend developing relationships with other members of your team, nurses, psychologists, whoever they are, or with other medical specialties, that's not thought of as work or of value. So the time spent on it is not counted and not measured, not funded, and therefore not thought important. So I think it has an effect both ways. And your talk made me think about all the various times I felt I could have handled it differently or thought about what was at stake. So thank you.
Thank you.
Dr. Gopchandran, in this context, do you think the consumer protection law, which has come in India, has this had a kind of role in changing the doctor-patient relationship? What is your take on that?
Yeah, so there has been this huge resistance for doctors to be subsumed under the consumer protection law. And that debate, that discussion and debate has been quite a strong one. And I think it is important. Most of the time in the history of medicine in India, we have been a self-regulated body. We have been a body which who have been regulating ourselves through the MCI Act and then the NMC Act and the various codes and things like that. And if you look at the history of how effective this regulation has been, that leaves much to be desired. We haven't really been that effective in the way we have regulated our practice. So I think some amount of accountability mechanism through these kinds of Consumer Protection Act and Clinical Establishments Act and acts like this, which impose an external accountability mechanism, I think are important in their own way. They have a role to play because as a self-regulating body, we haven't really been that successful, I think. That's my take on it.
Okay, thank you.
Sure, I'm open to debates and if there is a opposing view on that.
Vijay, Dr. Gopchandran, I'd like to sort of half respond to that if you don't mind. Because one of the questions I was asked when I was in Kerala recently and delivered a talk on professional stress was, are there hospital attacks in the UK? Do patient groups come in, harass and beat up doctors in the UK? And I said, I've not heard of hospitals being attacked, but there is violence against doctors. It's possibly less physical, but more of verbal violence that doctors here undergo. And so I was asked a question of why that might be. And somewhere in my mind, and I stand corrected by this body because lots of doctors in India today, I think in the UK, if a patient has a complaint, they have a system that they can take it to. It might not be effective, it might not be as patients want, but they know that there is a pathway to it. And I wonder whether in India we lack a system where a complaint can be taken up and and dealt effectively. Perhaps Dr. Gopi Kumar might be able to tell us the IMA.
A valid point, that is, because there is no easy way for the patient to go through. That is, you have the judiciary, you have the other fora, but it is very difficult for them, and it takes a long time, probably months and years to settle down. But probably that is why the new Clinical Establishment Act in Kerala, now it is being implemented now, that has got a clause for a redressal forum at the hospital level. The grievance redressal forum, which involves there are persons who are from the society also included in that. Not only the hospital authorities, not only from the doctors' sides, but others also are included in that. And a district redressal forum is headed by the collector, the DMO, district medical officer, and others. So that system is there in the new Clinical Establishment Act, which was not there previously. And probably patients were not in a position to have a grievance redressal at an easier way. Yeah.
Arun?
Yes, Shaji, please.
Yeah, just thinking about, our own training issues. We are all trained in tertiary care centers, and inadvertently we are trained to become more like tough teachers and then medical officers. So that kind of power seems to be groomed by the time you become a senior resident. I have heard in Thrissur Medical College, one junior resident, second year or third year junior resident, talking in the casualty that she went for a consultation and the first year JR did not show enough respect. See, this is inadvertently fostered. So my question to Vijay is also that do we, by the end of medical education, learn to trust each other? This is a big question. And the aura of the super specialist, I sometimes, once a patient prevented me from cutting a prescription which I thought was unnecessary, who was a DM from our own alumni. So I told them that since I happen to be his teacher also, he may not mind it. But patients are scared that such senior, highly specialized people, if you don't take the medicine which they prescribe, that doctor will get offended. That is what people think. So they are very scared to tamper with any of their prescription, or somebody, they wouldn't dare to go back to that doctor and say that Dr. Shaji said that you should not be taking this medicine. So I think that kind of situation is real. I'm sure it happens in surgery and everywhere. I'm sorry to say this. At this age, maybe I should speak the plain truth.
Dr. Vijay, actually, you mentioned about the using the stethoscope and feeling the pulses. But our patients actually, I mean, not the rural probably, but in an urban setting and in our state, are the patients satisfied if you are just checking the pulse and then writing the prescription? Because they are expecting you to write some investigations. And also, are the doctors on the other side, are they kind of forced into a defensive practice nowadays that if you're not writing a scan or proper investigations, going by your guts and writing a prescription nowadays, will it be counter productive, and actually, if something goes wrong, then you'll be held liable. So, what do you think about that scenario which is happening now?
Very true. I think this is it's kind of a vicious cycle where we think that we want to do investigate, and patient expects us to investigate, and it just goes on and on, the vicious loop. I don't know. I have never practiced full-fledged in an urban setting, in an affluent private kind of a setting. Most of my practice all my life has been in non-profit rural areas. And one thing I do see a lot of young patients who are from affluent backgrounds in rural areas also, and they demand certain tests and investigations and things like that. And I don't think I have so far never had a situation where reasonable discussion and conversation can convince or make people understand that such a test is not required. So I think I've also always had a lot of luxury of time. So in all my practice, I have been able to spend time with my patients, and that I know that's a luxury that people from government medical colleges and government institutions cannot have. That's a major difference. I do see where your question comes from, and I think I don't have an answer for that. I think that's something we should collectively reflect on and probably find solutions for. But yeah, it's very difficult. It's very complex.
Remembering Jimmy might have something to add. Jimmy has written many stories actually in his collection about the rural practice as well as a super specialist, so-called neurosurgery. So, Jimmy, what do you
No,
want?
no, I really enjoyed the talk. I would describe it as illuminating as well as hard hitting. So it really asked us to reflect on what we do. Thank you so much for that, Dr. Gopchandran. This fantastic talk. Many things seemed so familiar, but as you said, no, the first thing which struck me, which struck me was that we have two Indias here, and maybe I feel that there are three or four Indias, and you may be mostly seeing one India or one and a half of Indias, and we may actually be seeing. See, I'm in a tertiary care center, which is still not a corporate, but we see upper middle class and above. So when we investigate, it is difficult for us, and I mean we end up over investigating, though we never ever we do not get a cuts or anything from any benefit from over investigating. But especially in cancers and all that, we have had a lot of issues. For example, when we have a sarcoma, we sometimes order a CT chest. So a CT chest is all that is required. I mean, that is what is recommended. That's all. So when we do an MRI of that area, and then we order a CT chest. So that's all that is in the guidelines. But the PET is so much available in the city. So many of our patients end up going somewhere else and getting a PET. So a substantial amount of these patients, not too small a number, come back with some finding on PET. Then it is made out into sometimes a big issue and all that. Of course, then we tell them, see, this is all that is required. Some people might advise you a PET, but at the present moment, it is not really required, and it is not in the guidelines. But then some of them end up asking, we'll do a PET also because they have the money. Then we have to oblige, I feel, because otherwise we could land in problems. There are a lot of complex issues here, but many of your points are very well taken regarding patient trust and loss of trust in India is to a large extent our own problem. I'm not saying each individual consultant's problem, but as a community, uh, we have a problem. And we are also helpless because there is a system here of hospitals and private players, mostly private players, and an evolved system which doesn't offer us a lot of wriggle room So our agency is also limited, I would say. That's what I would say.
Vijay, could I make a point about? I really like the issue of touch that you brought in, and it just came to my mind that touch is a sort of a metaphor for trust in the doctor-patient relationship, I believe, because the doctor fears to touch because of the consequences that it might have in certain contexts, not in all contexts, perhaps not so much in the rural context. The patient fears touch, again, perhaps because of their own issues. So it becomes a sort of a metaphor for the issue of trust there. But the other the issue that you brought in, and how can one touch a patient? And I'm using it as a metaphor. And for me, there's something around how we talk about communication skills. Because a communication skill means a to and a fro. You're treating the patient as as an object, as somebody sitting in front of you. And I think there's something about that relationship where you can touch the patient through having a conversation, actually. So if you have a conversation, you have a human to human touch without actually physically touching the patient. So I love that metaphor that you brought in about touch there, Jay. Thank you for that.
Thank you. I never thought of it as a metaphor, and now I have taken back something from what you've said. Very interesting. Thank you.
Anybody would like to make any comments or any queries?
I think stethoscope thing was very nice, and Abraham Varghese, I think 10 years from now, people might not do much of an examination. It's not, I had an opportunity, a close relative getting examined in CMC Vellore abdominal examination. The first call was doing that, but I could very well make out that she had not done many. The way she did the abdominal examination. Me and Reena sitting there, we saw how it was something like a ritual which was done for the sake of making notes, kind of thing. Because she was sure that there was nothing wrong, kind of thing. For just completing the case record, went through that cursory kind of abdominal examination.
I think communication it's a big element actually. Not only, I think this also came through interprofessional communications, how we communicate with our colleagues as well as the patients. We are all nerds. We have to admit that we are all nerds from our student days, and then don't have a formal kind of communication training in our curriculum in India. At least now 8Com has come. So probably this is why we are feeling more and more detached from other people, including our colleagues. So this is reflecting in our practice with patients, and I think it is more and more pronounced in the younger generations, Gen Z as we call, or millennials, and they are experiencing more and more detachment, which is not good. So your talk was so insightful in that aspect also.
Vijay, in the context of ASHA, I hope you'll take your research forward to look at when the doctor becomes the patient, what happens to trust in the doctor-patient relationship. I hope you'll be able to come back to us and talk to us about that at some point of time.
I don't know. First thing to be missed when I had consultations was that nobody wanted to do a neurological examination. Finally, I told one neurologist friend that I am coming to Trivandrum. First thing I will do is to lie down on your couch and you will do a detailed CNS examination. Everybody said this peripheral neuropathy, you do all that other tests. Nobody touched me. And one doctor from Thrissur said this problem is very universal. And if the doctor happens to be a lady doctor, then all the more reason less physical examination. So I think this also, they say if you are taking a close family member to another doctor, this is also skipped. I think all these send very wrong messages.
I think Sudarshan had something to say. Sudhi?
Thank you very much. I got another thing to say actually. Just like Dr. Vijay, I am also staying in a rural place for the last 39 years. Of late, the younger generation are commenting about the drugs which I use now because I am using the older drugs. And of late, I had an experience that after MD, for 4 years after MD, one consultant was telling, Dr. Sudarshan, you are using an old rustic drug, which nobody does use. So that means the interpersonal relationship as well as the patient, to grab the patient properly, generations are taking new techniques. So I doubt whether the genuinity of the younger generation, how they are treating the patient, are they that much sincere to the profession? Like that, it has become just a questionable to me. Probably I am ignorant in this field because I am in a rural area. One thing like that. Second thing, that these investigations, nowadays people in our place, they would want to have only minimal investigations. But once we are not investigating, the other says that no, you haven't done anything except the routine BP checking and the other things. But if people may not be looking at the financial status, doctors may not be looking at the financial status of the patient because they have to afford the cost, they may not be able to afford the costly drugs. So with the minimum drug in minimum cost, we have to have a judgment for these people. Another thing is that to establish a rapport either with the patient, we are working in psychiatry, so just like other, not like other patients, to establish a rapport with the patient or the relatives, it's a must. But sometimes it takes long time to establish a rapport, the doctor-patient relationship with the patient. So these are little bit changes we have to have in the practice of the psychiatry. That's the only thing. Anyway, very good talk. Thank you very much.
Thank you, sir.
Saju is also there. Saju.
Did you want to say something, Saju?
No, that I was there from the beginning, but missed out some of the question and answer kind of things because there was a call. Yes, like everyone said, it was quite good, and the dynamics of trust and the overall relationship. It also throws up lots of questions, isn't it? The respect that the doctor feels for the patient. I think that's also a key concept here. And sometimes even humility, because we are trained in India. I'm in UK, but trained in India for many years. So that attitude of humility and respect is something that we were not trained in our medical school kind of time, and that's what is happening here. You are absolutely showing the most respect towards the patient, and you are not ashamed to say that you don't know these things, you need to check out and come back to you. So that way there is no pressure to adopt a kind of role as a all knowledgeable kind of doctor, which is also important. So patients can see that you are trying to help them in a genuine manner. That's all.
Shija, is it time to
Yes, sir. I
bring
think
Jimmy?
it's 9 o'clock.
So, Jimmy.
Oh, okay. I mean, there is nothing much left to tell, and it was a fantastic talk. And first, I would like to thank all the audience for interacting well, and it has been very fruitful and enjoyable. I thank you, Gopi Kumar, Dr. Gopi Kumar, for the future IMA president. IMA is an extremely important organization, and we hope to have collaborations in the future, and it's very important for doctors. And I hope IMA will do more for this type of cause, which is very, very important in the future. Thank you so much. And I already talked about about Dr. V Gopchandran's talk. It was fantastic. Thank you so much. I really enjoyed it. Thank you so much. May you continue your good work. That's all I want to say. Thank you all.
Thank you.